A male, 86 years old, and on February 2008, she was submitted to a Whipple resection for pancreatic neuroendocrine tumor, grade 2. Two liver metastases were found and multiple cellular mesenteric lymph nodes. She is stable since January 2015 on lanreotide. Diarrhea recurred with increase in size of the celiac lymph nodes. First session of lymph node US guided radiofrequency ablation was performed 2 weeks ago. We can see in the MRI the lesion and then the US and the radiofrequency ablation. The Italian group related to 22 locally advanced pancreatic cancer treated with cryothermal ablation with technical success of around 73%. Early complications were not so severe as abdominal pain and amylase level rise. And the most common complication was jaundice. Now we are going to the room number 2 to see the second section.
So you heard about the history of this patient. So as a patient with a relapse of neuroendocrine tumor, and now Mark has already performed a treatment of first big lymph node. If we are able, we can check which lymph node he has treated before. Here you can see a big one as well, very close to the celiac axis, and this is the bigger one that probably has already been treated by Mark in his previous procedure. This is to me is the best option for the treatment, because you should know that the device that we are going to use is the Cryotherm Pro by Irby, that we can show, if you want, is this one. It's very close. Thank you. My assistant, you see it, my assistant. So this is the device. You see that the handle is like a needle, a fine needle, aspiration needle, but the needle outside has two electrodes, because it is a bipolar device. So the tip of the needle, and this is the first probe. Then there is an insulation part, and then there is the second probe. And this is the distal part, which is only for endosonography confirmation to be inside the lesion. This is long 3 centimeters nearly. So the problem in this case is that you have to treat at least lesion more than 2 centimeters in length, to be sure to be safe and not over-treat something surrounding. So it's very important for us to be, so we retreat. It's very important to leave the needle not that far away from the distal part of the tube, because this tube is quite soft, so you should penetrate the tube when you push with the needle.
It's a large needle.
It's a large needle because the distal part is nearly 1.8 millimeter in size, so the diameter is really a large needle. You can see that we can do color flow Doppler. There is a vascular pattern in this lesion. I think that we don't need until now to perform any other sonoview before the treatment. We can determine with elastography that is still a hard lesion to be treated. So our goal now is to pass the needle. Usually first we test the needle to see whether there is any leakage in the flow of the CO2 inside the needle. So we can show you, because due by the fact that we have CO2 going inside. This needle performs not only radio frequency but also cryo. So we test. Yeah. So it's working, and probably is okay. No leakage, no bubbles inside, so
Okay.
we can start. And if you touch it now, is cold because of the cryo effect. So first of all, we put the needle and fix the needle in.
And just a question,
Yes.
Paolo. We've discussed this before. Is only effect on local effect, or we expect some systemic effect after the cryoablation?
This is a great question. The idea is that that there are several studies about cryo that show that using cryo you can obtain also an increase in immunomodulation of this of the response to the treatment. So what we think is that probably we could increase our capability to increase the immuno response to the lesion, to the treatment, and to the tumor. Because when you perform a necrosis in the tumor, you also particularly, this is the case of neuroendocrine tumors. You know that we are doing that for adenocarcinoma in the pancreas. We know that the antigens, the specific antigens of the adenocarcinoma are inside the wall of the cell. So when you create a necrosis, a local necrosis of the cells, the antigens comes out, and so the immuno response could be increased. And the other way is because the cryo is can determines an immuno reaction.
Yeah,
And
because
so
my oncologists
immunomodulation.
are more interested more than in the local effect.
Absolutely.
They expect more in an adjuvant, as adjuvant to the standard chemotherapy, mainly in those locally advanced pancreatic adeno.
Yeah.
And
So-
also in this kind of net.
So this is like a standard needle. So you see the tube, and this is the distal part of the needle. So I try to push the needle into the lesion. So this is the most important part. So
Okay.
here we are in. I try to go in with the whole needle inside. So
So
the
it seems
tip,
to be quite
yeah.
feasible and quite
This
manageable.
the tip is the penetration of this is very nice because all the tube, particularly the distal part of the tube, has a coil.
Okay.
So the possibility of penetration is very nice. So
Okay.
it's okay. I think that we fixed 3 minutes because it's nearly 3 centimeters. But the most important thing in this machine, this is a 300D Vario with the cryo machine inside, is that everything is connected to a computer. So there is a software that you can see. Probably we can show that. Everything is connected with the computer, so it's the computer that usually calculate the impedance of the tissue to the cryo and to the bipolar radio frequency. And so when the impedance of the tissue is decreasing to a certain level, the machine stops automatically, because there is the most important thing is that the effect should be completely under control. So
Okay.
I think that we can leave it so we can show how it goes. I can start the treatment. So I have started the treatment. You see all the lines going, and you see that there is some artifacts down here because of the treatment. But I think that quality of the image is still good. So you see that all the lines are very far away from one or from the other, so it seems that the treatment is effective. And you can see that here we can look to we can see the number of seconds the treatment, and you see here that the treatment is flowing into the lesion. You see here the current is flowing into the lesion. So it's very quick procedure. The problem actually is that in our experience in big reference centers, we usually have very small neuroendocrine tumors. So in this case, the treatment could be an over treatment for this patient because the lesions are so small. But in this case, I think it's very effective. It's really very effective. We are doing actually 144 seconds, 145 seconds. The machine is still working. You see, you have to take a look to this line and this line. So you see that they are reducing. So now they, okay, you see that for the machine, the treatment was effective because the two lines collapsed, and so we treat 2 minutes. 2 minutes. So now we wait just for a while because the probe should be warmed, because when you have an ice ball inside the lesion, it could be very difficult to remove the needle. So we stay just few seconds inside, and then we can easily remove the needle from inside, and we can remove everything from the device. So you see, we spend
From the ultrasound image, we can see that the needle track,
the
puncture
ultrasound
track has
imaging
been,
of the treatment is like that. So this is the area where the needle were inside, and this is the lesion that we have ablated until now. So this could be our treatment in this situation. So 1.8 and 1.7, 1.8, 1.8 necrosis. We can try to put some Sonoview.
Please.
Oh, wait for me because I have to change. Okay, thank you.
Yes,
Yes, because I don't have this machine at
but it's
home.
quite
This
similar
is
to the one that I have in the unit.
this is too nice for me. Oh yes.
Too low, huh?
Yeah, we should.
0.20.
Okay.
We increase.
Will be better.
Yeah.
Okay.
Okay. We can go.
Start.
Yeah. Start.
Inject,
Voila.
inject.
Inject. Thank you. Very welcome. Okay, you see.
And what do we expect to see from the Sonoview, Paolo?
We expect to see no enhancement in the area of the necrotic tissue that we have obtained. You see here clearly the injection was gone. Okay, perfect. So we wait for a while.
No.
And you see that the area that we have treated have no enhancement at all. This is usually what we expect for this kind of treatment.
On this area now, it's difficult to just to show this. This is very important for the injection of Sonoview.
Needs to be direct into the vein.
Direct.
You
With
see?
no filters
Yes.
in between.
You know that you should inject in the direction of the vein, not
that way.
perpendicularly, because if you inject the Sonoview perpendicularly, you will break
the bubbles. And the other thing very important is never inject inside here, because there is a filter here, and so all the bubbles will be damaged. So
this is
directly from this
small
area.
trick, but very big effect. Okay, perfect, Paolo.
Thank you very
It's a
much.
Very nice case.